Hey guys, we're gonna try this. I'm sitting out in my truck. It's raining, but I have to have the windows open because it's really hot in my truck. So you might hear the rain and some birds and I don't know, people coming and going. So I kind of look a little crazy sitting here talking to myself in my truck. But you know, hey, why not? Let's try it. All right. So the PowerPoint that I want to use is the PDF file that has the tubing. I guess it fit totally when I'm sitting here in the Dells. So um, let's get started. So this is just the different types of tubes. One goes straight into the stomach. An NG tube goes into the nose, down into the actual stomach. Another one can actually go straight to, yes, Ari, come in. Hey guys, um, wanted to get this out there. I've been trying for days actually. So right now I'm sitting out in my truck in a rainstorm, looking like I am talking to myself. My window's down because it gets really hot in here, and there's people coming and going, so I look a little crazy. But anyways, so the PowerPoint that I wanted to use is the PDF one, just because I think it's got better information about NG tubes. So, and I figured it fit well because I'm here in the Dells, so alright, let's get started. So this is just a picture of different tubes, the NG tube, the G tube, there's also a J tube. Depends on where the end of that is actually sitting. So that her first picture's got the tube going into the nose and down into the stomach. The other one is just going straight into the stomach, and you can kind of see the pictures there. So I know my group kind of went through it, the actual process of it, but this is more of the why of how to do it. So anyways, G tubes, or NG tubes if it goes through the nose, is just a flexible tube that goes in through the body, whether it's the nose or a surgical incision in the belly, and ends up in the stomach, the duodenum, or the jejunum. And it's used for different things. If there is issues where the stomach needs to be decompressed, if there's fluid or gas in the stomach, if somebody has overdosed and the toxins are sitting in their stomach, kind of absorbing into them, the stomach might actually be flushed and all those toxins may be taken out. A lot of times you're going to see it so they're administering food and not a cheeseburger, or meds. If there's a bowel obstruction, they're going to have an NG tube generally, and it's going to be sucking out all of the gunk that's on the top side of the bowel obstruction. And it can also be used if there's like a GI bleed and there's trying to get the blood out of the stomach, because blood is actually a natural laxative. So if a person has a GI bleed, they're going to be going and going and going. So the big things that I want you to remember is decompressing the stomach. It might be what's called lavaging the stomach and removing those toxins. Administering food. There's a special formula. Administering medications. And you'll see it most with treating the bowel obstructions. The different types of tubes, like I said, the NG tube is generally a Levin tube. It's got one lumen. It's usually more used for like a short-term feeding or a short-term suctioning, and can be through the nose, through the mouth. A Salem sump is what you guys will see most often in practice. It's got the two lumens, and it's the one with the blue on it here. The blue thing can actually double as a plug when you are getting your person up. If they have their tube to suction, when they get up, you're going to have to stop that suction, so you can just put the blue pigtail into it, and it can be capped. It's also an air vent. So, going on to this slide, if that tube is used for tube feeds or medication, you need to check placement each and every single time you use it. especially if it is an NG tube. I can't tell you how important it is to check that placement. And generally you can check, or generally you want to check for residual. So if it's used, if you're giving tube feeds every 4 or 6 hours, you want to make sure that they're digesting that food. So if you pull back and you're getting a whole lot of the formula that you have just put in at the last feed, something's going on and they're not digesting that food. You need to watch for any aspiration, because sometimes they will vomit up that formula. And it also will help for people who are at risk for aspiration, because they won't have to swallow. It'll just go straight down into their stomach. If you are giving meds through the tubes, it definitely needs to, the meds need to be crushed very, very good. They need to be very fine and dissolved in water, so that they go down well. Obviously, don't crush any of the enteric-coated or the long-acting medications, because that person's going to get a big dose. Generally, if there is an issue where they need a longer-acting med, it's going to be given as a liquid. So just know that if they do have the enteric-coated or the long-acting meds ordered, you're going to need to go ahead and get a new order so that they can get the liquid. The new evidence-based practice is that you give one med. Generally, I give 30 mLs of water in between each med so that you're flushing the tube. It kind of goes back and forth, because back in the old days, we used to actually just mix all the meds together, put it in one cup, check placement, flush the tube, give all the meds in one swoop, flush it again, and be done with it. But now they're saying that it is best practice to flush, give a med, flush, give a med, flush, give a med. So just know that that is the new evidence-based practice. If the person is dehydrated, yeah, you can give them extra water through the tube. And then always keep these guys' heads up, because if that formula or that water or that medicine backs up, they can aspirate, they can cause a lot of other problems. This picture is just showing you guys what the issue is when, if somebody is inserting an NG tube and it can actually perforate the esophagus, because you can see in here where it's going through the skin. So basically, when you're doing it, what this means is don't force it. It should go in pretty easy. So don't force it. All right. Alright, my papers are all mixed up. Okay. More uses. If you have a patient that can't eat or won't eat, an NG tube may be placed. The patient that I remember the most that I worked with was a young lady who had anorexia. And she'd been to court. She had court-ordered meds. She had court-ordered feedings. But she still saw herself as fat. I mean, she was like 21 years old and 80 pounds. But she still saw herself as fat, so she would not eat. So they court-ordered an NG tube. She ended up pulling it out. They placed it again with a weight, and then somebody thought they saw her pulling it out. So she got mad and said, "This is me pulling it out." And they actually ended up bridling it. They ended up suturing it to her nose. So a person that can't or won't eat, patients that have like burns or cancer, or maybe they're septic where they aren't able to eat, trauma there too, like a car accident. Anytime a patient requires bowel rest, where they're not eating like actual food, or that needs to be suctioned, there's an upper GI bleed, if they need gastric content for a study, a test, and then for suspected bowel obstruction. These are just the different ones. There's an NG tube, there's a nasoduodenal, a nasojejunal. There is also, just so you're aware, there is a where it can actually go in the duodenum or the jejunum through a surgical incision in the belly. Anytime you see gastric, that just means that it is going into the stomach. And generally an enteric feeding tube is going into the small intestines. Oh, people are coming out. Let me pause this. Okay, I am going to back up a little bit. I just watched 30 people crawl out of the condo next to me, and now the people on the other side of me are grilling and they're loud. So I'll try not to get distracted again. So the first picture here is an NG tube, an NGT. Goes in through the nose, down, and into the stomach. Generally, it can be for feeding, but it's mainly for suction. The middle one is a nasoduodenal tube. And the third one is a nasojejunal tube. So if you see the duodenal and the jejunal tube go straight into the small intestines. These are considered an enteric feeding tube, and most times these are for feeding. So they will end where they need to be so that they have more nutrients absorbed from the formula. So what are the benefits of a tube? Prevents a lot of aspirations. People can get aspiration pneumonia and actually pass away from it. Meds and nutrition are able to be given in a safe manner, and it can actually suction out the contents. I have seen people start NG tubes feeling terrible, and once that suction started and got that crud out, they actually felt better pretty quickly. Concerns with them, because there are benefits and there are concerns. Ari, quit moving, please. Aspiration, because I told you before, sometimes they get too much in their stomach and they just upchuck it, so that stuff can come back up, and then they can, and it can go down into their lungs. They can also have nasal erosion, because that tube rubbing in their nose. They can get esophagitis, which, obviously there's a tube rubbing on the back of their esophagus, so it can cause some inflammation there, and it can also cause a gastric ulcer. So, what do we need? We need a tube. Generally, it's an 8 to 12 French. The Levine is the single lumen, and the Salem Stump is the dual lumen. We need a 60 ml syringe, tape, or one of those fancy sticky things that hold the tube in place, a cup of water with a straw, an emesis basin, the safety pin. Not really sure why rubber band's on here. I've never used a rubber band, but towel or something to protect the patient, gloves for us, suction equipment. We need a pen light, a tongue blade, and a stethoscope. So first, obviously, we're going to check our order, make sure the doctor has ordered an NG tube, and we're also going to see what he wants it to do. Generally, it's going to be an intermittent or a continuous suction, and then he's going to have, how high the suction needs to be. Then we need to understand why our patient needs it, because if they having a bowel obstruction, needing to get that crud out that's making them feel so terrible, is totally different than if they need it for nutrition. All right, so then we are going to assess our patient's nose. Look through their nares, see if there's any deviation. Ask them if they've ever had a broken nose, because a lot of times broken noses aren't set, and so there is some sort of a deviation. Make sure that the nair you're going down is not obstructed in any way. Then we need to assess their belly. We need to listen to their bowel sounds, any issues that they might be having, so we can get a baseline. And then we need to see how they can swallow. A lot of times that's why they're getting an NG tube, but we need to know that for when we put it in. We're going to get a history, their meds, like I said, their nairs. We need to assess for their gag reflex. If their gag reflex is reflux. Their gag reflex is very, very sensitive, then this could really bother them. We also need to assess their mental status, and I'm not talking just like a younger child or somebody with dementia. Like I said, that young lady who ended up having a tube court ordered, we need to assess for that as well. So we're going to go in, we're going to introduce ourselves, we're going to do our patient identifiers, we're going to do our assessments, and we're going to explain to them what is going on and why we're doing it and how we're going to do it. We're going to tell them a way, we're going to discuss with them a way to communicate with us while we're putting that tube down, because they will have a hard time talking. Obviously, we're putting it right down where they talk. So I always say, put your hand on my side, and if you need me to stop, just hit my side, and that way I'll know that you need me to stop. We're going to position our patient, high Fowlers. We're going to put that towel over them, so in case we do spill any gastric contents, it's on that towel, and I don't know if this is going to turn out. I'll listen to this and see if it works, but it's getting kind of loud in here. But high Fowlers, we're going to have that towel on, and then we're going to have their head back. We're going to put our gloves on, and then we're going to look at our tube and make sure it's all intact. We're going to determine our length next. Oh, I suppose I should change the slide. We're going to determine our length. So we're going to go from the tip of their nose to the tip of their earlobe, and then down to their xiphoid process. We can mark it with tape. We can use a Sharpie and mark it that way. However, we need to know that that's the line that we need to reach going into the nose. We're going to lubricate that tube of the tip of the tube. Generally, I say about 4 inches, but as much lube as you can possibly do to make sure that it goes down smoothly. We're going to hand that cup of water with a straw to our patient, and we're going to tell them, don't drink yet, but I will tell you when to drink. We're going to start the insertion. We're going to aim back and down towards the ear. And while we're doing it, we can twist it so it goes in a little bit better. This is just the measurements of it. So then we are going to have our patient turn our head, flex their head, and put their chin down to their chest and drink the water with the straw, so that way they can, sorry, I've got too many people and I'm going to end up redoing this. We're going to have that patient put their chin down onto their chest and sip that water. And as they sip that water, we're going to advance that tube down into their stomach. We don't want them to drink the water before then, because when they're drinking, that's actually going to close that epiglottis and actually direct the tube down into the stomach rather than the lungs. When we reach the oral pharynx is when they start drinking. Do not force the tube down, because like I said, you can actually do an esophageal perforation. If that person is coughing, choking, or they're turning blue, we need to stop putting that tube in and we need to pull it back and get it out of there. If it's going down smoothly, then we advance to that mark that we put on there, either with the tape or the Sharpie. Once we're done, we're going to ask our patient to talk. With the tube in place, in the right place, they can talk. If that patient cannot talk, it is in the wrong place. So if they cannot make any verbal sounds at all. So then we're going to take our pen light and we're going to have them open up our mouth, and we're going to look in the back of their throat and make sure the tube is in the back of the throat and it's a straight line down. If they're able to talk and that tube is running down the back of their throat in a straight line, not curled up, not sitting there, that's when we secure it down. I've actually had patients where we put it down and it balled up in the back of their throat, and when we went to look in the back of their throat to see what was going on, they opened their mouth and out came the tube. So it just went in their nose, down the back, and out their mouth. Needless to say, I think 6 of us tried, and there was no getting that tube down to where it needs to be. Then we're going to check the gastric contents. We want that to have a pH less than 5. We want it acidic because there's, gastric contents are acidic. They're stomach acid. On here it does say air auscultation, but I do not want you guys to worry about that. That is a very old practice. Generally we used to instill 5-10 cc's of air and listen to their stomach over where we were putting it in. We'd hear a bubbling noise and we'd be like, oh yeah, it's in. But now that is considered not a good practice. So please do not rely on the air auscultation. It is a very old practice. Evidence-based practice now states that the best way to check placement is with a chest x-ray, chest and an abdominal x-ray, so that you can see the tube in place and where it needs to be. More evidence-based. Like I said, it is so important to check placement every shift, every time you access that tube, just because it can move and be a lot of issues. Like I said, the gold standard is to check for, or to have the I can't even talk. I've got people coming up to the truck and the phone ringing. Gold standard is an x-ray immediately after we put that tube down, just to make sure it's in the right place of where we need it. And then I talked about doing the aspiration of the stomach contents, and that needs to be less than 5. Here it talks about that listening to the bubble again. Make sure you're measuring that length of the tube. You don't want it going too far or too short. We need to make sure that we are providing wonderful oral care. Their mouth is very dry and can have a lot of issues. People with NG tubes can suck on ice chips, but you need to keep a very close I&O, because when that melts, it's going to go into the stomach and the tube's going to suck it out. So you need to make sure you're keeping a very close I&O if they're having chips. Always check their nostrils. Make sure that they're patent so that they can breathe around that tube. Vital signs, lung sounds, because they can go in the wrong place and they can aspirate with this in place. If they have suction going, we need to monitor and record how much drainage they've had each shift. Can be bloody tinged for trauma or surgery. So just be aware that it can be a little bit bloody. But generally, if you're pulling out gastric contents, it's going to be like a light yellow, like a bile color, to I call it a forestry green. So just be aware that it can range from that light yellow to that dark green. And it does smell bad, especially with bowel obstructions. So, what do we document? We're going to document the type of tube that we put down, whether it was a Levin or a Salem sump, what time we put it in, what side of the nose, which nair we put it in, if there was any residual, if we needed to take a specimen, what setting we have our suction at, because remember we can be intermediate.
Daddy messaged you, so I said you were working, and he messaged.
Alright, back at this. I apologize. People know that I'm trying to record this, and I've had texts, I've had calls, and I've had people come out to the truck to find out what I'm doing. So, I apologize again. So, when we document, I think we kind of went through all of this. Starting back up at suction, we need to know what setting we're having it at, whether it's intermittent, whether it's continuous, and the amount of suction. We want to document if we're doing any feeding, what type the formula is, how much we're feeding, how often we're feeding. And of course, we always want to document the patient's response. Did they tolerate it well? Did they not tolerate it at all? So, person has the NG tube in place. It's at a risk for displacement. Alright. So, because the person might be vomiting, maybe that suctioning is kind of suctioning its way out. Maybe they're coughing, or when they're moving or transferring. Moving or transferring can also displace that tube. And like I said, that young lady that I worked with actually pulled it out a couple times. So, again, I stress to you, check placement every single time you use that tube. Before you put anything in that tube, you need to make sure that it is going where it needs to be and not in the lungs or any other place. Alright, so it's a good thing we are almost done, because I apologize. Alright, so when we're taking it out, we need to make sure there's an order. We need to have our patient back in that high Fowler's position. And we're going to tell them to hold their breath. I wish I had you guys here instead of in a recorded lecture, but it only makes sense. Remember this, we want them to hold their breath, because if we're pulling it out of their stomach, there's going to be some of that contents left in the tube, and if we pull it out and they breathe in just at the wrong time, they can actually aspirate that contents into their lungs. So we're going to gently and smoothly remove that tube slowly. We're not going to rip it out, but we are going to just continuously do it. You can have them also like bear down, and that kind of gets their mind off of it. It makes life a little bit easier. Then we're going to make sure that we're giving them good oral hygiene once that tube is out, because that gastric contents is just terrible on the teeth. And then we're going to document. And again, we're just going to document the time, the date, that we removed it, how patient tolerated it. And then after it's removed, we need to make sure that we are assessing for any type of, like, if it's used for suction, we want to make sure that they're not having any abdominal distension, anything on that orders where they weren't ready to have it removed. So, if you have any other questions, and I apologize, I have been, like I said, I've been trying to record the lecture for days, and I've waited up till everybody went to bed, and it didn't work. So, and I apologize for the rain sound, but I will listen to this and see if it actually works, and if that sound is too loud, which it might be with the recording that I use, and I will record another one. But I hope this works. If you guys have any questions, please get a hold of me and ask. I will be happy to answer anybody's questions.